in today's lecture, I'm also going to go over in which views do you see the zygapophyseal joints in the thoracic and lumbar spine versus the intervertebral foramina. Okay? You see the intervertebral foramina on lumbar and thoracic spine when the patient's in a lateral position. When the patient is oblique, that's when you see the zygapophyseal joints. Okay? But the oblique angles are going to be different between thoracic and lumbar. And for cervical spine, it's opposite. Cervical, it's the obliques that you see the intervertebral foramina, and it's the lateral that you see the zygapophyseal joints. So it's going to get really confusing. It's definitely going to be tested, just so you guys know. But I will have a chart in your guys' lecture that you guys can refer to. Yeah.
I was going to write it down, but
yeah.
never mind.
Yeah, no, you guys will see it again.
Okay.
Okay, so I'm going to put my marker right where I did for the thoracic spine, except now we're going to do lumbar. Okay, you're going to put your back on the board. I know, kind of jumping around. I'm going to feel for Mike's iliac crest, and then you're going to be centered right at that iliac crest. I'm going to bring this down behind you. Okay. Again, I don't want to see a whole abdomen picture, but you do want to have it open a little bit so you can make sure you're not clipping like the transverse processes. And again, if there's any curve, you want to be able to capture that. Okay?
And you said you're centering at the iliac crest for this one?
Yes.
Okay.
You do want some overlap with the thoracic spine. You do want to see up to T11 and then down to the sacrum. Okay? Some doctors want to see the acetabulum where the femoral head articulates with the hip. So all you do, you might want to just do a low lumbar, and then you will need to open it wider so that you can see that portion. The reason why some surgeons want to do it this way is because they're planning for surgery and they want to make sure the hips are even, and so when they're putting the prosthesis in, they're not throwing off someone's spine, so now they're walking with like a limp or, you know, crooked.
You want to make sure you get the SI joints, right?
Yes. But if you get the acetabulum, you'll automatically get all that.
Yeah, I'm just thinking a regular one.
Yes, absolutely. You want to get down. Huh?
So we sometimes do that at clinical,
Okay.
L5 to S1.
Okay. So that would be your AP lumbar. Okay. I'm going to show you what I do for lateral lumbar. So you're going to turn and face me. You're going to put your arms on this. So obviously you guys are not going to be using any rolling shields for this view. I typically have the patient just hold a rolling shield. I like it because then if I need to move them forward, the shield moves with them instead of something that's heavy that I have to go and pick up and move. You just have to be careful with elderly patients. Make sure that they know that there's wheels on it. It's going to be rolling forward so they don't put all their weight on it. Okay? And the reason why I don't use the bar for this one is because if someone's holding the bar, there's only so much forward that they can move before, you know, their arms start coming down and it gets in the way of the spine. So that's why I do it this way. So I'm gonna have you take a step forward, Mike. Okay. And then, again, you're gonna be at the iliac crest. Oh gosh. Sorry, I'm trying to not get in the way and then I'm messing myself up. And again, this looks like it, the central ray, when I went from AP to lateral, it looks like it went lower. That's because now there's magnification because he's closer to the tube. Okay? I'm gonna have you scoot a little more forward. Again, you're gonna be lined up right where the spine is, not too much. Come back. Sorry, I don't mean to be poking your side. I'm just trying to get you nice and lined up. And then I am gonna put my hand on his back, make sure that there's no rotation, just like you would for a chest x-ray, make sure it's nice and straight. I'm gonna put my marker in the light field behind the spine, particularly where there's that lordotic curve, okay? And then I'm gonna collimate to the spine. You can see there's a little bit of light right here. That's where my marker's gonna go. Okay, and you're at the iliac crest, overlap up to T11, and then you do want to go down past L5S1 so you can see that articulation. You do not need to get the entire coccyx on this picture. unless your clinical site, that's just a part of the protocol. Okay? I'm gonna show you guys the spot film now, okay?
Strike a pose, sir.
Okay. Now I'm gonna show you guys the spot. So typically when a patient is standing, you won't necessarily put an angle on the spot. The reason for the angle is because some people's hips move them away from the receptor and it kind of angles the spine, and so that's why you would angle caudally. Okay? I'm gonna have you come forward. You're still, oh, you're gonna face me, you're gonna just put your hands out. Yeah, that's fine. So, just to show you an example, I'm going to angle for this one. I am gonna be using the 10x12 cassette. So you're gonna use a smaller cassette, okay? And then, here, it's just kind of difficult for me to make sure you guys can see me. So what you do for this one, you'll see techs use a technique. They make a C with their hand. So you're gonna put the top part of your fingers on the iliac crest, okay? And then your thumb is gonna go down the side, and then your central spot, you're gonna want the ray of your X-ray to go right in the middle of where that C is, okay? And then you're gonna make a nice tight box to go over it, and that's all you need.
What's the angle?
5 degrees.
Oh, 5, okay.
For some women, the angle would be 8, and you can put your marker if it stays on there. Otherwise, you could put it on the board. You would just want to do it anterior so it doesn't get in the way of the tailbone.
This is the
Do you mind
spot.
placing your hand again? So
I
can
do
take a
not
picture?
mind.
How do you know where on the board to place it since you can't see the light field?
That's why for this particular one, I'll usually put it on their hip.
Okay.
It's easier when they're lying down,
Yeah.
because if they have a gown, it might
You
fall
can see.
off. Yeah.
And then would you always, like for the test, would you want us to just always angle, or do you want us to base it on their anatomy?
So it's going to be based on the anatomy.
Okay.
And also if you're tabletop versus standing. For standing, I would say most people are going to go straight on.
Okay.
But tabletop, which I'll show you, I absolutely will want to see the angle. So
Okay.
when you're on the table, there should definitely be an angle, and then it just depends on your body how it is.
Okay.
Because some women have really big hips, so they kind of lean into the board
Yeah.
when they're standing.
Mm-hmm.
And so that's the exception for standing.
So that'd be why you angle, is because they're leaning.
Yes, well, and their hips are kind of,
Okay.
getting in the way. Because when you see someone lying down on their side, there's no way for them to not lean, right?
Yeah.
So that's
Okay.
why we have the angle. For women, it's an 8-degree angle caudal. For men, it's 5 degrees. Okay?
Is that our L5S1 projection here?
Yes.
That's the spot view.
Yes.
Oh, spot, yeah.
Yeah, same
Yeah.
thing. Yeah. I'm gonna have you put your back against the board. Okay. Now I'm gonna show you the L-spine obliques, okay? So Mike, I'm gonna have you have your feet pointed towards mine. Okay? Just so you guys know, when you have your patient obliqued, it's easier for them to bring the arm that's closest to the tube behind and the arm that's by the board in front. Uh-huh. If a patient is a little unstable, I'll let them use their front arm to put on top of the plate, yeah, like that, just so that they can
So it's like a low
stabilize.
swimmer.
And then your patient should be at a 45-degree angle, so I'm gonna angle you a little bit less. And then remember, it's the spine, it's behind the patient, so the x-ray should be going more posterior than anterior, because it's gonna be the downside on the plate. And then I'll just stick my marker down at the bottom left corner, because he's an LPO. If he was RPO, then I would put my right marker on there. Sorry, I almost hit you in the face.
No, you're good.
And so this projection is where you would see the zygopophyseal joints, okay? And when the doctor's looking at this picture, they're gonna be looking at the posterior side.
And we're still at the iliac crest.
So you're gonna be at the posterior. So the downside is gonna be the area of interest for the doctor. Okay.
And for the just one more time for the L5S1, you start it at. Do you start the top of the C at the iliac crest or the ACES?
The top of the C is at the iliac crest.
Okay, got it. So that's always like our point of reference in one way or
Yes.
another. Okay.
Yes, and then you just curve your hand around, and then
Yeah.
just know between this pointer finger and your the thumb, you just go right in the center.
Okay. Got
Mhm.
it.
And the spot is a 10x12 plate.
Yes. Because, I mean, if you think about it, it's just like a little square. You
Yeah.
don't need a big
Mhm.
area for that. Okay. Well, if you guys are ready, I can start showing you the tabletop pictures.